technology. Down here in space. Change the slide.
I think so.
Great. Okay. I'm Diana Driscoll, and I wanted to thank everyone at ISNVD for having me. I'm extremely honored and humbled to be here in front of such a prestigious crowd. I wanted to thank also the Harvey Institute for Human Genetics for recognizing my work. Anyone who would love to contact me, I would love it if you'd contact me at prettyill.com. There's a doctor contact page. I disclose the following financial relationships. None. Most of my clinical trials and studies are self-funded. And one reason is that I am a patient, and I never thought of this as an advantage before, but it really is when we get in some of these strange illnesses that cause some strange symptoms. It's very difficult to tell what is going on unless you're actually experiencing, is what I found. I have Ehlers-Danlos syndrome, which is a defect in the collagen, and collagen makes up about 80% of our bodies. So we start off with one challenge already. We have leaky vessels and a leaky blood-brain barrier. We've already made that change from collagen 1 to collagen 3 in many parts of our bodies. So we easily go on to develop multiple sclerosis and other conditions. I have autonomic dysfunction, or POTS, postural orthostatic tachycardia syndrome, which is basically a breakdown of the autonomic nervous system that we see in the majority of Ehlers-Danlos patients. It also hits multiple sclerosis patients, but it's a subclinical presentation. They don't usually realize it unless they are tested. I have mast cell activation syndrome, which is likely secondary to an imbalance in inflammatory cytokines. And I'm starting treatment on that, and wow, what a response I'm getting there. So we're going to talk some about that too. I have CCSVI, those are my jugs there, and have been treated. I restenosed in about a week, which was unfortunate, but I believe I know why, and I'd like to share that with you too. I have one brain lesion with starting to develop symptoms of multiple sclerosis. I'm a therapeutic optometrist, so my background is eyes, and I thought the eyes really are the window to systemic health, and that opened the door for me to do continued research. So I wanted to start with, first as a review, Ehlers-Danlos, POTS patients go on to develop other autoimmune conditions such as systemic lupus, rheumatoid arthritis, multiple sclerosis, etc. And when I mentioned MS patients develop POTS, that was discovered in 2010 by Dr. Grubb and his team. My first clinical trial that I looked closer at the eye, and it's out at poster 154, is the vascular fundus changes with patients with high probability of chronic cerebrospinal insufficiency, venous insufficiency. And indeed, it was a small sample. I looked at 60 affected eyes and 60 age-matched normals, and was trying to see if I could tell the difference. Because I thought it would be great to be able to go to your eye doctor and have the eye doctor say, you know, it just looks a little bit like you may have CCSVI. I thought that would be magnificent. Well, it takes a great deal of magnification to do so, but with some magnification we can see that, okay, here is two eyes, and much like Dr. Simka said in his study also, one eye was generally much more affected than the other, and it was on the side with the greater stenosis. So on your right, I believe it is, you can see the enlarged vein here, hinting at poor venous drainage, and the arteries here. We saw an abnormal artery to vein ratio. The arteries were too small, the veins were too large. And on this other eye of the same patient, these arteries are ridiculously small, which may have something to do with endothelin 1, still looking into that. But we also saw a lot of atherosclerosis, even in the very young patients. And as we know, multiple sclerosis patients, Ehlers-Danlos patients also develop abnormal lipid profiles. And that is after we're triggered, after we kind of get going. So, and this is my image, and you can see, I hope you can see this, but on my right side, this vein here is not only enlarged, it's what we call beaded. And the arteries are too small and they're atherosclerotic, which is really discouraging, I'll tell you. On the other eye, the vein is much smoother, but you can see the artery again is way too small, an abnormal AV ratio. And then I ran a clinical trial because, and again, this is where it takes being a patient and kind of having children involved and being in the trenches with the patients really helped me out. because so many symptoms that patients were describing to me and that I was living with sounded like hydrocephalus. And then I would look at children who had problems since birth, and then kind of looked at my children and thought, well, they had a couple symptoms too. Did a retrospective analysis on children who have, or adults who have Ehlers-Danlos and POTS, looked back at their first 15 months of life, and indeed found that we were born with hydrocephalus. It looks like it's the external communicating form of hydrocephalus, which is oftentimes misdiagnosed. But when we were treated with that, we got a lot of relief. Many multiple sclerosis patients also have hydrocephalus in the literature. Now, I knew we wanted to increase oxygen perfusion. I oftentimes felt like I was suffocating, and many of us did. And poster 147, I think, is a good summary of this. We know that the cerebral perfusion pressure is equal to the mean arterial pressure minus the intracranial pressure. My apologies to Dr. Raj, because that is as much engineering as I know. But to decrease the intracranial pressure, I did what most eye doctors do, and that is I grabbed that old expired bottle of Diamox in the back of the cabinet that we all have, but we very rarely need to treat emergency glaucoma patients. And I downed a couple of those, got immediate overnight relief, which was amazing to me, due to likely, I assume, the decreased protection of cerebrospinal fluid. But it also has a couple other mechanisms. One, it removes fluid from the interstitial space in the brain, which is likely one reason it's effective in altitude sickness. But I didn't realize I was as brilliant as I was until Dr. Hagee said it was brilliant, because he participated in a study not that long ago that measured an increase of almost 40% of oxygen perfusion in the brain of patients taking acetazolamide. So I thought we were onto something. Of course, we can decrease intracranial pressure, hopefully with angioplasty. And then comes in the question about the transverse sinus, and a lot of us have this stenosis transverse sinus, and that perhaps could be a cause of hydrocephalus, but there's conflicting studies out there. The study, or the MRI there on the right, is a patient with Ehlers-Danlos who has external communicating hydrocephalus. And one reason this is so underdiagnosed is somehow physicians get in their minds that we need to see papilledema or swelling of the optic nerve head, or at least enlarged ventricles, to have hydrocephalus, neither of which is the case. In external communicating hydrocephalus, we have increased fluid pressure in the subarachnoid space, mainly above the brain here. There we go. Above the brain, you can see that extra fluid. And we'll see that down the spinal canal also. I'm presuming it's because our arachnoid villi are not working properly and we're not able to drain into the superior sagittal sinus and out through the transverse sinus. That is pure conjecture at this point. Now, mast cells I knew became involved, and we'll get into this in a little bit, but I wanted to introduce it at least, because mast cells release over 60 very powerful chemicals. They're supposed to help us heal, which they can when they're in balance, but they can get way overbalanced because when they spit out their histamine and other inflammatory cytokines, they actually recruit T cells and astrocytes to also spit out inflammatory cytokines. And they are kind of the Ponzi schemers, if you will, the inflammation cascade. They make it amplify tremendously. Now, what histamine or anesthesia, for the anesthesiologist here, or inflammation can do is it compromises the blood-brain barrier, which is made of astrocytes, of course. Now, if you can imagine, the compromise in blood-brain barrier puts fluid in the interstitial space, causes vasogenic cerebral edema, an increase in intracranial pressure, a collapse in brain capillaries, an arrest of cerebral perfusion, and then damage to the astrocytes, which unfortunately leads us back to further compromise of that blood-brain barrier. That's a very vicious cycle. It will also cause damage to the oligodendrocytes and myelin, and I knew we needed to break that cycle. Did so immediately with mast cell medications, H1 and H2 antagonists, mast cell stabilizers, and we were greatly improved, but there is still more to it. Now, I had to mention this because I found this way cool picture, and everybody asked about optic neuritis and glaucoma. If my cursor work. Okay, this is the dura mater here up at the top. This bottom part is the optic nerve. This canal here, it looks like a river, is where the cerebrospinal fluid is. And you can imagine if there's a drastic increase in inflammatory cytokines or an increase in pressure or just garbage, if you will, getting in there, that it can damage the structure there in the middle, that big dark structure, there we go, the arachnoid villi. And that is usually what takes out that extracerebral spinal fluid down into these canals and then drains out through the venules of the eye, and out she goes. So if we can fix what is wrong with the brain, we can fix what is wrong with the optic nerve. I really believe that. The optic nerve is the only cranial nerve that is considered to be a direct extension of the brain. It comes right out of the lateral geniculate nucleus, the only one that does so. And the studies out of Vanderbilt indicate that glaucoma looks like it is originating up at that connection with the lateral geniculate nucleus and working its way down from the brain instead of vice versa, where we always thought the pressure inside the eye was causing the damage and working its way up. Now we're kind of re-looking at that. Now, balance, I think, is everything. I do believe CCSVI is congenital because I could see symptoms in myself, my children, other patients that hinted at it, but we were able to overcome it, rose above, until we were triggered. And holy cow, I was triggered with a virus. It put me in bed for 3 years. This was not subtle. My son was also treated with a virus. Hydrocephalus is also a trigger for this. Hydrocephalus spills out an increased number of inflammatory cytokines. That's not good. Extreme stress, positive or negative, and as you know, an accident, say a car accident. I feel people triggered by that also. That is where the inflammatory cascade begins, and the mast cells amplify it. So if this trigger is chronic, for example, if the stimulus is still present or if the blood-brain barrier is still leaky, you can imagine that the inflammatory cytokines in the cascade continues. Now, how do we know that inflammatory cytokines are a big part of this picture? I really wanted to know that. Poster 158, please feel free to take a look. I learned that in Ehlers-Danlos, we developed left ventricular diastolic dysfunction, which at first was of intellectual curiosity until I developed it, and then all of a sudden I was highly motivated to figure this out. Well, I did a little research and discovered that multiple sclerosis patients also develop a subclinical level of left ventricular diastolic dysfunction. They don't usually know that. We don't think we diagnose a multiple sclerosis patient, say, oh, better go run and get that echo. But somebody else figured that out. So what I wanted to do was look closer and see what is happening on a cellular basis, what is happening on a chemical basis to cause this change in tissue, no matter what the overlying cause was, if you will. I learned that an increase in myocardial stress, like fluid stress on the tissue, if you can imagine, plus endothelin-1, which deserves a whole hour by itself, plus the matrix metalloproteinases. If you add to that the increase in inflammatory cytokines, especially tumor necrosis alpha, interleukin-1, interleukin-6, those are the biggies, will cause collagen degradation and ventricular remodeling. And that sounded just a little bit like a CCSVI to me. Now, inflammatory cytokines are bad, bad dudes. And think in terms of this with either making a valve go bad or restenosis, because they cause fibrosis, inflammation, endothelial cell apoptosis, thromboembolism. We work so hard to avoid that after angioplasty. An upregulation of cell adhesion molecules, etc. That is bad. Now, and then of course the mast cells get in there and amplify it. We call that the mediator release syndrome. One thing that also hints toward multiple sclerosis being a little bit different as far as inflammatory cytokines is that multiple sclerosis patients are very prone to anterior granulomatous uveitis and pars planitis. About the only other conditions we see that in is a sarcoid. And pars planitis is what we consider an intermediate uveitis. That's inflammation in the middle part of the brain. And I always wondered when I saw this, in the middle part of the brain, why the middle? What was so special about that? Well, it is special. And I learned that the mast cells love the choroid. And the choroid is this pink area here in this blow up of the eye, if I can get the cursor to work here. And it's not working. But it goes all the way around the inside of the eye. It's covered up by the retina up until you get to the pars plana. Can you see that little window there? There it is. And that is considered kind of like a escape hatch for mast cells, their mediators, and inflammatory cytokines to go into that middle part of the eye. And indeed, we can measure tryptase in the vitreous of these patients. The only cell in the body that will produce tryptase is a mast cell, not the cells they recruit. They won't spit out tryptase. So if we see tryptase, we know mast cells. Now these cells and the cells they recruit, the T cells, the neutrophils, etc., will actually pile up against the edge of the retina and what we call snow banking. So it is not subtle. It is not subtle at all. Now, I'm trying to step back and look at all these conditions, the family, if you will, that may be related to CCSVI. And I can't help but drift toward multiple sclerosis. In Ehlers-Danlos and POTS, we develop chronic candida, as do multiple sclerosis patients. That is a signal of a lower immune system. It is oftentimes the first sign of AIDS in an AIDS patient. Now, in that picture on the left is esophageal candida. Okay. Also, our HPA axis, the hypothalamic pituitary axis, just goes nuts. We call it endocrinology gone wild in Ehlers-Danlos. I had an endocrinologist say that my panels were basically impossible. So it goes nuts. So what I did is I looked at 23 symptoms that I had, because it's all about me, and tried to see what these other conditions had in common with Ehlers-Danlos and POTS. And I pulled out 9 of them to show you today, because this is where it starts to get interesting. So heads up.